Good afternoon to everyone present here. Today we'll be looking at imaging of intracranial hemorrhage. So coming to the intracranial hemorrhage, first when we look at the anatomy of the meninges. So basically the meninges is divided into three parts. First we have the dura mater, which is the outermost covering of the brain, and it has an outer periosteal layer which attaches to the bone, and an inner meningeal component which is under it. So then we have the arachnoid matter. We can see the white color arachnoid matter here. It is also called there are granulations. You can see this black thing. These are called arachnoid granulation, also called pachyonian granulations. And then we have the pia mater, which is encasing or lining the brain tissue. So what is there is between the pia mater and the arachnoid mater we have the CSF. So CSF fluid is there, and between the periosteum, outer dura, and the inner dura, we have two layers of the dura. So what actually happens is leptomeninges is nothing but arachnoid plus pia mater. So coming to extradural hemorrhage. Extradural in the sense it is outside the dura. So we told you there is a periosteal layer. When there is a fracture, a patient comes with history of trauma, head injury, and there's a fracture, then what happens is there will be rupture of the blood vessels. So what happens is there will be collection of blood between the dura mater and the skull. Okay, so what happens is there will be collection of blood. So bleeding between the dura and the skull. Usually it occurs in children or in young adults, and there will be fracture of the temporal bone. When there is fracture in the temporal bone, that is over here, there is a middle meningeal artery coming over here. So that blood vessel ruptures, and this causes a hemorrhage called as the extradural hemorrhage. So the patient usually have a lucid interval. What is lucid interval? The patient falls, then the patient has loss of consciousness. Then the patient regains consciousness, and the patient walks away or drives his vehicle and goes. After some time, the patient has loss of consciousness again. So this is called as lucid interval. Why does it occur? That's because due to the initial impact of the shock, the patient may lose consciousness. But as the size of the hemorrhage increases, it compresses the brain, and there will be mass effect, midline shift, and all the vital structures of the brain get compressed, and because of increased intracranial tension, the patient loses consciousness again. So then the patient obviously will have headache. Increased intracranial tension will cause vomiting, nausea, and again symptoms of mass effect. So coming to the modalities of imaging. So when patient comes to the emergency with history of trauma, and the patient has history of loss of consciousness, and you see there's an extracranial swelling with the loss of with bleeding, you have to do a CT scan of the patient. So CT scan is basically to look for hemorrhage or intracranial injury when patient is having a road traffic accident or a trauma. So this white structure what we see is the skull. Okay, then this bright structure which is biconvex in shape, this is called as the extradural hemorrhage. So hemorrhage will be bright on CT. See the same thing we can see here. This is the non-contrast enhanced CT. So 95% of the cases will be unilateral, and it will be supratentorial, and dura is tightly adherent to the skull near suture lines. So what happens, you know the dura mater, we have the suture lines of the parietal bones here. So the dura mater, the periosteum layer will be attached to the dura here in the parietal, and parieto-temporal suture, that area it will be attached. For example, we have the temporal bone here, this somewhere here parietal bone is starting, so the dura is attached here. So a hemorrhage which is occurring over here will not cross the suture line usually. So when it does not cross the suture line and it is biconvex, then we tell that it is a extradural hemorrhage. So there are some exceptions. If there is fracture across the suture line, or it's a venous EDH, venous extradural hemorrhage, then it can sometimes cross the suture line, which is rare. So we can see here there is a fracture here, and there is some blood vessel is ruptured. You can see the blood flowing in. You can see a swirl. So the same thing seen on CT, it appears somewhat like this. So when the hemorrhage in the brain is not uniform in density, and we can see patchy areas of hypodensity, that is black areas, then it is supposed to be a hemorrhage which is still ongoing. That means the patient is still bleeding. So what you see now is not the status of the patient. If you image the patient or take a CT, repeat CT after some time, then the hemorrhage would have increased. So this is a case which you have to promptly intervention by the neurologist, neurosurgeon is required. Usually the hemorrhage attains its maximum size in 36 hours. And the low density swirl sign means active or rapid bleeding. So extradural hemorrhage can be venous extradural hemorrhage in 5 to 10% when there is a fracture line which is crossing the dural sinuses. We can see these are the transverse and sigmoid sinuses here. So, or if it is crossing the superior sagittal sinus, we can have a extradural hemorrhage in the vortex. So extradural hemorrhage can cross the falx and tentorium cerebelli. This is because I am going to tell you about SDH, where it cannot cross the falx. Dural sinuses, if it's above the sinuses, extradural, it will be compressed inside, and CT is the best imaging tool. So extradural hemorrhage requires prompt treatment. Most of them require to be surgically evacuated because there will be increased intracranial tension. And mixed density require aggressive treatment, like I told, because it's ongoing bleeding. And some EDH less than 1 centimeter, no cerebral edema, the patient is fine, then you can manage conservatively. Repeat CT in first 36 hours to monitor for change. Or if patient has symptoms, you can image the patient earlier also. Anterior middle fossa EDH are venous and usually do not require surgery. That is, when it is in the anterior part of the temporal lobe, anterior to the temporal lobe, then it mostly is venous. Coming to the next type of hemorrhage, which is subdural hemorrhage. Subdural hemorrhage means we have the dura, it is below the dura, but it is above the arachnoid. So between the dura mater and the arachnoid mater, there is a subdural hemorrhage. Okay, so subdural hemorrhage does not follow anything called the suture lines. So it can be seen from the frontal, parietal, temporal, occipital. Or the whole hemisphere can be involved because dura, which is attached to the suture line, is above it. So under it is the arachnoid mater, which is a smooth continuous layer. So the whole hemorrhage can be continuous. So it can cross the suture line, but it does not usually cross the midline. As you can see, the arachnoid membrane folds inside along the falx. So usually it will not just simply cross the suture line. If it is there on both sides, usually the falx also will have subdural hemorrhage in relation to it. So see, you can see this membrane is continuous. There's nothing which is stopping it. So this hemorrhage can enter adjacent to the falx. The same thing with the tentorium cerebelli. So there will be some bridging. You can see some blue color veins here. Now this veins will be crossing this potential space between the dura and the arachnoid. So usually when this get ruptured, this is the reason for subdural hemorrhage. So anticoagulants, elderly, alcoholics, and patients with cerebral atrophy. In cerebral atrophy, what happens is the skull size will remain the same, but the brain will become small because of atrophy. So there will be increased space. So when the patient has some trivial trauma or the patient is on anticoagulants, there will be a rupture of the veins and there will be hemorrhage. And usually it will be subdural hemorrhage. And sometimes the patient will be asymptomatic for a long time, and the patient has came with some vague long-standing history of some old trauma which they have forgotten. And you see there will be a chronic SDH, subdural hemorrhage. So on CT, as I told you, it crosses the suture line and it is concave concave inside, convex outside. So concave or convex. In contrast to the extradural hemorrhage, which is biconvex, it will be convex inside also. So this is the one of the pickup points where we say it is a subdural hemorrhage. Hyperacute is when it is less than 6 hours, we call it hyperacute. Acute is 6 hours to 3 days, and 60% will be homogeneous. 40% will be mixed, and when there is patchy areas of black areas inside, then we call it there is sign of active bleeding. So you can see in this patient there is a subdural hemorrhage here. Due to the mass effect, there is some edema also in the brain. So due to the mass effect, this you can see the lateral ventricle here, right side is fine. Left lateral ventricle is not seen clearly. That's because it is compressed. It is compressed and there is midline shift. You can see the between the ventricles, this area is shifted to the midline. So it's this is supposed to be here. It has gone so much into that side. That means patient is having severe mass effect. So this is life threatening and this needs to be intervened. So this is the falx cerebri. This is the tentorium cerebelli. Tentorium cerebelli. So you can see it's thickened, some hemorrhage along it. This is subdural hemorrhage along the falx and tentorium. So you can see that, you can see the brain is normal. You see here there is something here in this area. So this is called isodense. Iso means same density as the brain. So it is almost same density of brain, so we are not able to see it. This is called isodense acute SDH. So when patient is having anemia, the density of blood will be less. So that is our patient is having coagulopathy, then the density of blood will be less. Blood will be thin. So in that case, SDH may not be seen easily. So that is called isodense. So subacute SDH also will be isodense. That is more than 4 to 5 days after the history of trauma. The blood will lose its density and it will become almost equal to brain. So we can see here there is something here. It's very faint. It's very difficult to see this. Look at here. You can see the gyri and sulci separately here, but here you are not able to see it. So this is a isodense subacute subdural hemorrhage. The same thing here. So as more time passes, what will happen? The density blood products will break down and it will become more darker than the brain. So you can see this here. So this is late subacute subdural hemorrhage. Chronic subdural hemorrhages when all the blood products have degraded and the fluid becomes almost like CSF and only some hemosiderin residue, that is the product of degradation of blood, will be there. So you can see this is the CSF in the ventricle. It is almost as black as the CSF in ventricle. So you can see on both sides it is there. It is chronic subdural hemorrhage. That means it's there for a long time. So sometimes what happens is the patient will have recurrent subdural hemorrhages. That is either history of recurrent trauma or the patient is on coagulopathy or atrophy, alcoholic patient. So recurrent is having some trivial head injury and multiple times he is having hemorrhage. So what happens is there will be some membranes formed and it will form locules. So there will be areas of acute hemorrhage which is bright and areas of old hemorrhage which is CSF density. So this will be multilocated mixed subdural hemorrhage, acute and chronic together. Sometimes what happens, there can be calcium deposition inside the subdural hemorrhage instead of getting resorbed. So this is called calcified subdural hemorrhage. Coming to subarachnoid hemorrhage. So you can see there is blood ruptured in the subarachnoid CSF space. So where there is supposed to be CSF, there is blood. This is called subarachnoid hemorrhage. So most of the cases of head trauma, subarachnoid hemorrhage will occur. So it is one of the most common hemorrhage which occurs in a road traffic accident. It's due to tear of the cortical arteries and veins. That is on the top of the brain, whatever small blood vessels are there, when it gets ruptured, the blood leaks into the subarachnoid CSF space. So when there is choroid plexus bleeds, there will be bleeding into the ventricles. So as we can see on CT again blood will be bright. We can see instead of the normal sulci which we can see here, which is black, you can see the sulci black, you can see instead of that there will be bright areas. So we can see there is subdural hemorrhage also. Usually in trauma there will be multiple types of hemorrhage in the same patient. You can see some blood in the sylvian fissure here, this is subarachnoid hemorrhage again. So sometimes there can be aneurysmal rupture. So when there is aneurysm is small outpoachings in the blood vessels. When it ruptures, it will lead to thunderclap headache. That is, the patient will tell, this is a sudden onset headache has come, which is the worst headache of my life. So that patient will be around 40 to 60 years, and most of the patients will be hypertensive. So you can see that we know that circle of Willis in the basal cisterns, that is down anterior to above the pons, above the level of the pituitary, suprasellar region, the circle of Willis will be there. So any aneurysm, most of the aneurysm will be there around that area in the circle of Willis. When the aneurysm ruptures, there will be blood in the basal cisterns. It has gone everywhere into the sylvian fissures, prepontine cistern, mesencephalic cistern, quadrigeminal cistern, everywhere all blood has gone, and sometimes the blood will go down and enter the ventricles through the foramen of Magendie. So then it will cause intraventricular hemorrhage also. So this is a life-threatening situation. So usually caused by saccular berry aneurysm. Okay. So this is a small aneurysm. These are the two branches of anterior cerebral, left and right anterior cerebral artery. So there will be anterior communicating artery, that bifurcation area, there is an aneurysm here that has ruptured and caused a subdirectoid hemorrhage in the interhemispheric fissure. An aneurysm which is more than 2 mm in size can be picked up on CT angiography. Coming to cerebral contusions, so most common type of intracranial injury, it is one of the most common type, and it is there is something here. The patient had history of trauma, and we mentioned all the subarachnoid hemorrhage, subdural hemorrhage, all those things were written in the CT report, and the patient, they sent for follow-up the next day. So what happens is then the report will come as that there is lot of contusions in the frontal lobe, in the temporal lobe, some contusions are there. Why it was not picked up in the first CT? That's because this contusions is basically edema, same like contusion in any of the tissues in the body. There will be areas which will be injured, and that will be apparent only on the delayed scan most of the times. If it is very severe and it is hemorrhagic contusion, that is a contusion which has bleeding inside the brain parenchyma, it will be visible on the first CT scan. If it is a non-hemorrhagic contusion, contusion is there but there is no bleeding inside the brain parenchyma or brain tissue, that will be usually more apparent in the second, third and fourth day scans and so on. And this contusions can be countercoup injury. Patient has got a hit on the back of the head. See, this patient has got a head injury in the left parietal region. So you can see the extra in the scalp swelling in the parietal region, but the patient has got a contusion in the diagonally opposite frontal lobe of brain. So this is called countercoup injury. Okay, opposite side. That's because when there is impact here, the brain tissue goes and hits the skull on the other side. So this is the first CT. There is some mild subarachnoid hemorrhage. We are not able to see the contusions here, and in the delayed images after a few days we can see there is this contusion has become more apparent. So coming to intraparenchymal hemorrhage. Intraparenchymal hemorrhage is a hemorrhage which is occurring inside the brain parenchyma. It is a hypertensive intracranial hemorrhage. So this is a type of stroke, hemorrhagic stroke, where when there is increase in blood pressure of the patient, there is a rupture of some blood vessels inside the brain tissue and causes weakness of the opposite side of the body. So this patient is having a hemorrhage in the left lentiform nucleus. You can see this is the lentiform nucleus. So in the putamen, he is having a hematoma inside the putamen. So the patient will obviously be having weakness of the sudden onset right side weakness of the body. So hypertensive intracranial hemorrhage is 10 to 15% of all the strokes. So what is the rest 80 to 85% of all the strokes? That is when the blood vessel gets occluded, it is called ischemic stroke. So this is 10 to 15%. Most common site is putamen, basal ganglia. Second most site is in the thalamus. Then third is pons cerebellum. Then lobar, any other place in the brain. Coming to intraparenchymal hemorrhage, we can see that there is a hemorrhage and there is filled with red blood cells. So depending on the time of hemorrhage, this is hyperacute hemorrhage. So there is blood inside, red blood cells with hemoglobin inside. So this is hyperacute hemorrhage, which is less than 24 hours. So this red blood cells has oxyhemoglobin inside. So as the blood clots, which is 1 to 3 days, the oxygenation will go and it will become deoxyhemoglobin. And then what happens, it starts degrading. So early subacute clots, that is more than 3 days, 3 to 7 days, that will be it will start forming methemoglobin, but it will be inside the cell, intracellular methemoglobin. Late subacute clots, again the membranes will rupture and it will come out. So this will be methemoglobin outside, and then everything will get lysed and it will shrink. So this is called gliosis. So it will cause dilatation of the ventricles, widening of the sulci, because there will be space there, it will shrink a little. So in CT we have a hyperacute hemorrhage. So we can see there's a big hemorrhage in the left cerebellar hemisphere and a small hemorrhage in the right cerebellar hemisphere. And here we can see after some time, a few minutes later, CT repeat, the right cerebellar hemorrhage has increased. So this is a hyperacute or ongoing hemorrhage. And when we look at the CT or MRI of any patient for that matter, we are always looking at the leg end of the patient. Patient is lying on the gantry like this. This is the head of the patient. This is the leg of the patient. So we are taking a CT section cut like this. So this is when we look at the patient, this is the right side of the patient and this is the left side. So same thing, this is the left side of the patient, this is the right side. Okay. So again, just want to show some MRI images also. This acute hemorrhage. So MRI, there are multiple sequences called T1, T2, SWI. SWI, the bleed will be black, and T1, T2, depending on the age of the bleed, the signal or the appearance will vary. So, subacute hemorrhage, T1 and T2, it will be bright. T1 CSF will be black and T2 CSF will be white. Rest of it will come to it in the other classes. Then we have intraventricular hemorrhage. So we can see the lateral ventricle, right and left lateral ventricle is filled with hemorrhage here. So intraventricular hemorrhage occurs due to primary causes and secondary causes. Primary causes is hypertension. Hypertensive bleed can have intraventricular hemorrhage. Vascular malformations, when it bleeds or ruptures. When the patient is on anticoagulation therapy or patient is on coagulopathy, or intraventricular tumors which bleed, again intraventricular hemorrhage can occur. And it can extend from the intraparenchymal hemorrhage. I showed you a hemorrhage inside the putamen. Similar hemorrhage in the basal ganglia anywhere can rupture into the ventricle and cause secondary hemorrhage. Or subarachnoid hemorrhage I showed you, it can enter through the foramen of Luschka Magendie and it can come into the ventricles. So there is something called as hypertensive microhemorrhage. This is a sequence of MRI called SWI. You can see in cerebellum, you can see this black dots inside the pons, you can see small black dots in the thalamus, in the lentiform nucleus, and in the brain parenchyma you can see small dots. But when you look at the number of microhemorrhages, as black dots, microhemorrhages, it is more inside the basal ganglia, thalamus and pons and cerebellum. This is called hypertensive microangiopathy. That is, because of hypertension, there will be small microhemorrhages inside the brain. Also called as Charcot-Bouchard aneurysm, which is prone to rupture. There is something called amyloid angiopathy. Amyloid angiopathy, usually we differentiate from hypertensive angiopathy in the sense that this basal ganglia, cerebellum, all those things will be spared. Instead, there will be hemorrhages in the brain parenchyma itself, and there will be subarachnoid hemorrhages. There will be a lot of small micro hemorrhages in the brain parenchyma. There will be cortical microinfarcts. There will be white matter changes, all those things. You can see this compared to the basal ganglia here. We can see lot of dots in the cerebral parenchyma. This amyloid angiopathy is accumulation of cerebral amyloid beta in tunica media and adventitia of leptomeningeal and cortical vessels. So there will be lobar intraparenchymal hemorrhage and cerebral microhemorrhages at grey white matter junction and superficial to, it spares the basal ganglia and pons. So there is something called as diffuse axonal injury. A patient comes to the casualty with history of a road traffic accident, but what happens is we take a CT. Patient's GCS is very poor, patient is unconscious, so you are expecting a severe head injury, but when you take a CT, the CT scan report comes out to be normal. That means you are not able to see anything in CT. That is the situation where this clinical and CT mismatches there. So that is when you have to do an MRI. In MRI, there is a sequence called SWI, which I showed you earlier, to look for bleed. So you have to look for any small microhemorrhages in the grey white matter junction. So this is a case where there will be due to shearing force, there will be injury in the grey white matter junction. There's a grey matter, that is the nucleus, and the white matter will get separated. So the patient will go into coma. So summarizing today's class, so we have looked at extradural hemorrhage, which is outside, which is biconvex. Then we have looked at extradural hemorrhage does not cross the suture line, usually associated with fractures, and it is usually emergency. And subdural hemorrhage, it can cross the suture line, it is concavo-convex, and it can cross the suture line, usually venous bleeding. This is due to arterial bleeding from intermeningeal artery. Then we have subarachnoid hemorrhage. Then we have intraventricular hemorrhage, and we have small bleeds due to hypertensive microangiopathy in the basal ganglia. Then bleeds in the cortex due to amyloid angiopathy, and diffuse axonal injury, where there will be at the grey white matter junction, there will be small bleeds. So this was a summary of the class today, where we looked at the different types of intracranial hemorrhages which can occur. Thank you.